Good morning. It's my pleasure and honor to call for the start of the next or session 2 of the cell therapy day about cell and gene therapy symposium. I'm Tariq Aweda, consultant hematologist and transfusion medicine. It's my pleasure to co-chair with Dr. Abdullah Al-Jifri, consultant pediatric hematology and bone marrow transplantation. It's my honor and pleasure to introduce the first speaker, who's Dr. Christina Duncan from Dana-Farber Center Institute, Boston Children's Hospital, Massachusetts, USA. Dr. Duncan is a pediatric hematologist oncologist with an extensive experience in the field of pediatric hematology and stem cell transplantation, particularly in non-malignant diseases. Please, Dr. Duncan.
Hello. Thank you for allowing me to present in this format. I certainly would have rather been present with you today, but the decision was made by our institution not to let us travel, so I apologize for that. So thank you again. What I'm going to present today is gene therapy for childhood cerebral adrenal leukodystrophy, which is a rare pediatric disorder. So this is an X-linked disorder that is caused by mutations in the ABCD1 gene, which leads to impaired expression of the peroxisomal half transporter of the ALD protein. This protein is needed to degrade very long-chain fatty acids. So as a result of the mutation, the very long-chain fatty acids accumulate in the tissues to toxic levels, primarily in the adrenal glands or in the central nervous system. The estimated incidence of this disease is 1 in 17,000 boys, 1 in 17,000 newborns, or 1 in 21,000 boys. There are 4 forms of this disease, and there's no genotype-phenotype correlation even within a family. And so for some of the boys, they present with no symptoms whatsoever, and that is certainly ideal. Other patients have adrenal insufficiency alone. Some have the adult onset adrenal myeloneuropathy, which is a peripheral neuropathy, and others present with cerebral adrenal leukodystrophy. Cerebral ALD affects 35 to 40% of boys and is the most severe neurologically devastating form of the disease. And so the clinical course of a boy with cerebral ALD, they are initially obviously asymptomatic, and then some of their early symptoms can include things as simple as poor school performance, behavioral problems, and in some cases they're misdiagnosed as having diseases such as attention deficit hyperactivity disorder. This progresses then to a moderate disability, which can present with problems hearing due to auditory processing, aphasia or apraxia, so difficulty communicating verbally, vision impairment, dysphagia, walking or running difficulties, episodes of incontinence or seizures, and then ultimately cortical blindness, loss of communication, tube feeding, wheelchair dependence, and loss of total voluntary movement and incontinence. On the bottom of the screen, you can see a representative MRI of how this regressed in a child with cerebral ALD, so to very mild symptoms at first to at 24 months, very severe disease. It's important to note that the severity of the symptoms doesn't always correlate with the MRI, and you can have a child who's asymptomatic who has evidence of demyelination on MRI, and so it's very important for children to undergo routine screening MRIs to try to identify disease early in the course. Cellular therapies are currently available for cerebral ALD. The current standard of care is allogeneic stem cell transplant, and then available on treatment, which we'll spend most of our time talking about, is autologous gene therapy. The goal of cellular therapy, either gene therapy or a stem cell transplant in this disease, is stabilization. And we know that transplant performed early in the course of disease progression can stabilize disease and clinical symptoms. It is important to note, though, that it is not effective for the non-neurologic manifestations of disease, so it does not affect the adrenal insufficiency, or is it expected to prevent the adult onset of the peripheral adrenal myeloneuropathy. It also doesn't reverse any neurologic findings that are present at the start of disease. And so children with more severe symptoms will still have those after therapy, and the disease may progress for 3 to 24 months after infusion, making it so important to identify boys early in the course of the disease. There are multiple ways that we measure the severity of cerebral ALD. The first is using something called the Neurologic Function score. And so this is an ALD-specific score that is used to identify the severity based on motor and communication defects. Having no defects would be a score of 0, and this goes up to 25 where you'd see more severe defects. And so each of these are told as so if you have writing difficulties, you get 1 point, and then they accumulate as you go on. We also use something called the LESS MRI severity score. And so this score is used to measure the extent and the degree of white matter changes in hyperintense regions, starting with 0 with no scores, or in this representative image, a LESS score of 1, to a more severe score, as you can see here with a more involved disease. And finally, we use gadolinium contrast enhancement as a marker for active disease. And so this usually being a halo around the original lesion. So a lesion may be present but inactive without enhancement, or show signs of activity with the activity present. So the data that I'm showing on this slide comes from work done at the University of Minnesota, where we look at the survival in this panel, so the panel on the left, of a large cohort of boys, so 283 patients who were both treated with transplant and those untreated, to look at the natural history of this disease. And you can see over time, the natural history is of death, with a 43% loss of life at 10 years. And on the right panel, we see survival estimates for boys who had early stage cerebral ALD, so those who had 0 neurologic score on the motor score I showed you, or a low MRI score. The blue line on top are boys who were transplanted, and you see survival estimates at 5 years of close to 95%, and those who were not treated, the boys in the red bar, where you see continued progressive loss of life over time, so indicating that transplant can be effective in this disease. The efficacy of transplant, however, is very much determined by the number of neurologic deficits and the MRI severity score that you have before transplant. So again, work coming from, led by Dr. Peters at the University of Minnesota, we see the solid line on the top being patients who had few neurologic deficits and a very mildly or less severely affected MRI, having excellent survival, and boys who were transplanted who had more deficits over time or a higher score on their MRI, having inferior survival. So again, highlighting the point that we should identify boys over time or early. The data I'm showing you here comes from a portfolio that was performed as part of the gene therapy package. And so this, though, is looking at the natural history of patients transplanted more recently at multiple centers. On panel A, this is the survival of boys who received a stem cell transplant but who had advanced disease at the time of transplant. So in the black bar is the overall survival of those patients. And on the gray line, we see the major functional disability survival. So the patients in this panel are alive, but they accumulate major disabilities over time. In panel B, we see the survival in the dark bar and the major functional disability survival in the gray bar. And so what this indicates to me is that for a child with advanced and mild disease, we can certainly keep them alive longer than we probably used to advances in supportive care, but their disabilities accumulate over time if you have more advanced disease at the time of transplantation. In allogeneic stem cell transplant, your donor matters certainly, and in this panel on the left, you see the survival of patients who had a related donor, and in the panel on the checked line are those who had an unrelated donor. And this data is a bit old, so we expect the survival in both of these to be better over time, but showing us that related donors have a superior survival over unrelated donors. And so that's fantastic, but we know that not everyone who needs a related donor or needs a transplant has a related donor. So each individual sibling having a 25% chance of matching the other, and 33% of people, at least in the United States, who need a transplant having a matched sibling donor. So this gets at one of the needs for alternative therapies besides allogeneic stem cell transplant. And so this is data that came out of a U.S. registry looking at the likelihood of finding a suitable HLA-matched donor. And in the blue squares on top that I'm highlighting with the arrow now, this is the likelihood if you are of European ancestry in the United States of finding a donor. So actually somewhat favorable. But then if you look at other populations, you see that that is not nearly as favorable. And so the purple checks being patients who are of Middle Eastern ancestry living in the United States, having a likelihood of about half of those as others. So with this, along with the presence, as we know, of transplant-related mortality and graft versus host disease, along with the need to find a donor, to me highlights the need for alternative therapies. And that gets to our studies of gene therapy. So the primary study I'm going to talk about today is something called the STARBEAM study, or ALD 102. This is a global multi-center study of gene therapy in patients who have cerebral ALD. The key enrollment criteria were that children needed to be less than 17 years old at the time of enrollment. They had to have evidence of active cerebral ALD manifested by gadolinium contrast enhancement on their MRI, with early stage disease, meaning a less score, or that MRI score of 0.5 to 9, and very few functional symptoms, so the neurologic function score of less than 1. And in this study, the patients could not have a matched sibling donor available. The primary efficacy outcome is the proportion of patients who are alive and free of major functional disabilities at 24 months. And so major functional disabilities for this study defined as loss of communication, cortical blindness, the need for tube feeding, total incontinence, wheelchair dependence, and complete loss of voluntary movement. The primary safety outcome in the study was the proportion of patients who experienced grade 2 or higher graft versus host disease or chronic graft versus host disease by month 24, with secondary and exploratory efficacy outcomes being the change in the neurologic function score, gadolinium contrast enhancement, overall survival, and a less score on MRI. Additional key safety parameters we looked at were the presence of engraftment failure, adverse events, the detection of replication-competent lentivirus. We used an HIV-derived lentiviral vector, and the presence of insertional oncogenesis. One of the challenges we faced when designing this trial was how you determine success in a rare disease. So this is an open-label study. It'd be virtually impossible to do a randomized control trial, and so it's hard to know what to say means that we succeeded. And so the success of this trial came in the context of two other trials. So first, ALD 101, which is a retrospective chart review and data collection of pediatric patients with cerebral ALD, and that was data that I showed you earlier in this presentation. This was designed to understand the natural history of cerebral ALD as well as the outcomes in allogeneic transplant. We also then performed a partial prospective retrospective study of patients who received allotransplant, but this was performed with patients in a contemporaneous cohort, so people who were being transplanted around the same time as patients who were receiving gene therapy in order to give us better context. And in that portfolio was ALD 102. So this looks like a complicated slide, but I want to walk through. And this is how we defined our primary efficacy endpoint, and so what success meant in this trial. And so in the green bar, we see, based on literature and our retrospective review, the expected month 24 2-year major functional disability survival of patients who are not treated. And so for those patients, it's clearly inferior and something that we would not use to define success. The red is based on the retrospective work, showing us what patients who receive an allogeneic stem cell transplant would be expected and their survival. The black dots and the green line representing that same data but in the literature. And that's where we arrived at our benchmark of success. So our benchmark of success was that the lower limit of our confidence interval needed to be equivalent to that in the prior work. We didn't want to show that we were better necessarily than allogeneic transplant, but equally effective, and with a point estimate of survival of 76%. So what that really meant is that to be successful, 13 of our 17 boys who were enrolled in this trial needed to be free of major functional disabilities at month 24 from gene therapy. In this study, patient stem cells were collected after mobilization with GCSF and or plerixafor, depending on their response. The CD34 cells were selected and transduced in a central manufacturing facility with the vector. The boys then received myeloablative conditioning with busulfan and cyclophosphamide chemotherapy, and the stem cells were infused. We then expect the transduced stem cells to engraft and differentiate into microglia expressing the ALD protein and follow those patients for 2 years. After 2 years, they were then eligible for participation in a long-term follow-up study up to 15 years from the time of gene therapy. The data that I'm showing is mostly of a data cut from April 15th of 2019, where we have the most recent results. At that point, there were 32 boys who were enrolled and treated on this study. 15 of them had completed the study and were now enrolled in long-term follow-up study. That is certainly greater now. 14 were still on study 1 year ago, and 3 patients who we'll talk about in a little bit more detail discontinued therapy. The average age was 6 years, and the median follow-up of all patients was 21 months, with the longest at the time of this data cut being 5 years. The LESS score and the neurologic function scores at baseline were quite low in the study. In the primary efficacy endpoints, 15 of the 17 boys, or 88%, who were evaluable at month 24, met that survival mark, or the major functional disability mark. There was no evidence of major functional disabilities with the longest survival of 5 years. The 3 boys who did not or will not meet the primary efficacy endpoint, 2 of them were withdrawn by the study at the investigator discretion due to changes on their MRIs, with no apparent change in the function at that point, and referred for allogeneic stem cell transplant. And then there was another child who experienced major functional disability and death. There were no events of graft versus host disease by 24 months or the follow-up. We then enrolled an expansion cohort to gain more data to provide greater access. Of those, there were 12 additional patients enrolled. 1 patient withdrew at investigator discretion due to neuroimaging changes, and there's no evidence of major functional disability in the 11 patients present. What we saw is that the neurologic function score, so the gross neurologic dysfunction, was very much stable over time. This line, the dotted green line, are the boys who progressed the single boy, who progressed rapidly after transplant. So 30 of the 31 boys who enrolled had stable neurologic function score. 24 patients maintained a function score of 0 over time. 3 had a small increase of 0 to 1, and 1 patient had a greater increase from 2 to 3, and a second to 2 that was then maintained over the course of the study. We also saw that their MRI scores remained stable over time. There was some gradual increase as expected in the first 24 months after infusion, but then stabilized. And here we see an MRI of the first patient enrolled, who's now over 5 years from the study, who their score at baseline and their MRI at 2 years, where we would have expected to see much more rapid progression with the natural history of the disease. One thing that we're following closely is that of gadolinium contrast enhancement, and that all boys had contrast enhancement present at the start of the study that initially resolved, and in some boys it's returned over time and then ultimately resolved as well. The character of that is quite different than it was at baseline, and we're still trying to determine what exactly that means. In regards to the safety profile, the vector copy number per diploid genome was 1.2, with a drug product cell dose of 11.4 CD34 cells per kilo. Neutrophil engraftment occurred at day 13, and platelet engraftment at a median of day 32. The adverse events reported were very much consistent with what would be expected with myeloablative conditioning. And so what we determined from this is that we think the safety profile appears very similar in what you expect with myeloablative conditioning. There's no evidence of graft failure and no evidence of replication-competent lentiviral state. One very important thing that we follow in these patients is integration site analysis of the boys treated. There was no evidence of polyclonal hematopoietic reconstitution with insertional oncogenesis to date. And so this table just represents the genes associated with the top 10 insertion sites that we see that is polyclonal across the patients. There is 1 patient who we're following closely who has had what we're calling benign clonal dominance of a single clone with 3 separate insertion sites as the genes listed, accounting for 10 to 14% of cells and 70% of the vector-marked cells. This child we've watched very closely and did a bone marrow to look for any evidence of oncogenesis, in which there was none at the time of that marrow. As of last month, this child continues to do well with normal tri-lineage hematopoiesis and is being followed very closely. Obviously, an important thing to follow in anyone receiving gene therapy is whether this is durable over time. And so what we see in this slide is looking at the persistence of the vector-marked cells over time, and we see stable persistence in the presence of the gene-marked cells, at least at the time of this data point of 48 months after infusion. We also look at the presence of the ALD protein in CD14 positive cells after the infusion, and we see that the protein is stable and present over time, at least up to 5 years, in 3 patients who at this point had met that endpoint. So in the summary of this data, this first study, ALD 102, has completed enrollment with 32 boys having received the product. 15 of the 17, or 88% of the evaluable patients, were alive and free of major functional disabilities at 2 years, so meeting our goal endpoint. 14 additional patients remained in the study with the longest term follow-up of 20 months. And as of last month, 23 boys were evaluable for the primary endpoint. There's been no evidence of graft failure, graft versus host disease, insertional oncogenesis as of April 2019, and we think that the safety profile is consistent with what we see with myeloablative conditioning. The integration site analysis shows polyclonal reconstitution. In that patient I showed you most recently, we're following benign clonal dominance with no clinical consequences to the patient to date. So we think that this product stabilizes disease, continues to show a favorable safety profile. It may offer an alternative to allogeneic stem cell transplant in patients with early cerebral disease. A question that we often get is why we need full myeloablative conditioning, and that's what we're investigating now. So the successor trial to this trial is open using busulfan and fludarabine conditioning rather than busulfan and cyclophosphamide conditioning. And the clinical trials number for that trial is there. We're currently open and enrolling on that study. And so with that, I would like to acknowledge the centers who participated in this trial, and obviously to the study's participants and their families, and to you as the audience for listening. And I know this is not an easy way to listen to a talk. So thank you very much. And if there are questions, I'm happy to take them now.
Thank you, Dr. Duncan, for this interesting results. And we have time for 2 questions. Okay. You can have that one.
Thank you very much for a very informative lecture. Being an ophthalmologist, or in reality a geneticist, retinologist, I noticed you had one of the criteria as cortical blindness. How was that actually categorized? Because we know that they present with visual impairment, and the visual impairment is totally different from your cortical blindness. And I noticed that was one of the major criterias to enter into the study.
Thank you. It's an excellent question. Perhaps maybe I can clarify that to a small point. Cortical blindness was one of the endpoints or the major functional disabilities that was being assessed. So none of the boys had cortical blindness at the time of enrollment. The boys had to be very mild in their symptoms of adrenal leukodystrophy, and so if they developed cortical blindness or any of these other disabilities listed, that was considered to be failure or lack of success in the study. And so you're right, it's very important. It's very important to follow their vision over time, but none of the boys had blindness at the time of presentation.
Okay, thank you. I think because of the sake of the time, I will move the mic to Dr. Jeffrey for introducing the next speaker. Thank you, Dr. Duncan.
Thank you very much.